because most caregivers would be administering ibrutinib initially, and that's certainly been the case because that drug has been evaluated and tested extensively for almost a decade or over a decade now. We're usually talking about ibrutinib as a drug that's given initially in the discontinuation. If it's for intolerance, it's reasonable to think of switching to acalabrutinib. There are a few studies that have suggested that acalabrutinib can be given after ibrutinib where the clinical response is maintained. And also that the adverse events are not necessarily augmented or that there are new adverse events. In addition, while we're talking about intolerance, if a physician, either caregiver, is switching from ibrutinib to acalabrutinib, there is a recent trial, the ELEVATE relapsed refractory trial, which is the first head-to-head comparison of the two drugs, that suggests that both drugs have equal clinical outcomes. That was a non-inferiority design trial, but it does look like the progression-free survivorship is equivalent for both drugs. So if one is switching from ibrutinib to acalabrutinib, you can be pretty confident that you will be able to maintain that clinical response, and that the toxicities will not necessarily be augmented. And in addition, an important outcome of that head-to-head comparison is it appears that cardiovascular events with acalabrutinib are lesser. So there is a lesser incidence of hypertension over the years, as well as atrial fibrillation, which are two major concerns for patients who are, for individuals who are prescribing drugs for CLL patients who need to be on these drugs. So, it's for ibrutinib-treated patients, there's an obvious other drug. And then for acalabrutinib-treated patients initially, there isn't necessarily a lot of data on whether ibrutinib could be used subsequently. But if it's for intolerance, perhaps that is not necessarily an easier transition, and many physicians may choose to go to a different mechanism of action drug, such as a BCL2 inhibitor, such as venetoclax. For individuals who progress on ibrutinib, so they have disease progression and would go on acalabrutinib, we have to remember that those two drugs have similar mechanism of action. And so if there are mutations that are present in the clone, such as a BTKi mutation or PCL gamma mutation, which are the two most common mutations that we know about, it's likely that that individual will also be refractory to acalabrutinib. Those are potentially going to be supplanted by newer BTKis, which are reversible, as opposed to the two current approved FDA drugs, ibrutinib and acalabrutinib, which are irreversible BTKi inhibitors. So I wanted to make sure to mention that there are these newer drugs are being tested and look very promising, and would be alternatives for use of BTKis in the future.